Now I come to the toric IOL surprise, calculation and correction of the misalignment. What is a toric IOL surprise? Presence of the cylindrical refractive error of more than 0.5 diopter post toric IOL implantation for the cataract surgery may be called as a toric IOL surprise. I have got a very simple logic. Does pre-operative keratometric power and access matters? No. Do we need any app like axiomatisfix.com? No. Do we need to take any photograph or slit lamp with any app to find out the axis of the IOL? No. We don't need it. Why? Because we know that the toric IOL work best in a steep corneal axis. That's it. So whatever it was before surgery makes no difference. What it is now, that is what is important.
So we can't hear you.
Yeah, just. So what you need is, you need to find out whether rotating or realigning the lens will decrease the astigmatism. So we need to put it, and whether we should rotate it or not, that is very important. Whether rotation is advisable and possible or not, that is important. So I'll tell you, whenever there is a toric IOL surprise, there are two components. One is non-correctable by toric IOL realignment, and second is correctable by the toric IOL realignment. So first we need to find out what cannot be corrected by even the best of the alignment, and then to calculate how much is the misalignment. So that means if there is a keratometric astigmatism and the lens, it can correct at the corneal plane. Suppose the patient had a keratometric astigmatism of 3 diopter and the lens can correct only 1.5 diopter. Use the lens which can correct at cornea 1.5. So that means whatever you do, there is 1.5 you cannot correct. So wherever you put this lens, because the cornea astigmatism is 3 and the lens can correct only 1.5. On the other hand, if the corneal astigmatism is 2 and the lens can correct 1.5, that means 0.5 cannot be corrected. And if the corneal astigmatism is 1.5 and the lens can correct 1.5, that means the full correction is possible if the lens is well aligned. If the corneal astigmatism is 0.75 and lens is 1.5, that means 0.75 cannot be corrected. So first, we need to find out with the existing, after the surgery, whatever is the keratometric value and what corneal plane this lens can correct, and detect that. You will find that this is a non-correctable value. This cannot be corrected, wherever you might put the IOL. So now once you have got non-correctable component, now with the refraction of the patient, we can find out what is the correctable component in this refractive surprise. So there is a total refractive cylindrical power. Whatever patient is getting the cylindrical power on his specs, and if you reduce the non-correctable component from that, the rest of it is correctable by the realignment. So in the same example, if you see that non-correctable component was 1.5 in the first patient and post-op refractive error was 1.5. That means there is no correctable error. Patient has to live with it because it was supposed to correct 1.5. It has corrected 1.5. So there is nothing. Realignment will not work. In the second case, the non-correctable was 0.55 and post-op refractive was 1.5. That means 1 diopter of error is because of misalignment, which you can recover, and the lens can be rotated. In the third case, where there was absolutely 100% correction was possible, you got 1.5. That means the lens was totally out of place, 30-degree misaligned, and it can be completely corrected. And in the third case also it can be corrected. So once you find out what can be corrected, then we need to reverse calculate the amount of the misalignment. If we correct misalignment, we do not correct the refractive error. The refractive error is the byproduct of correcting the misalignment. So misalignment calculation of axis is important to find out whether we should actually go in or not. I will just highlight just now. If you see that if there is a residual correctable astigmatism is of 1 diopter and total correction possible was 1 diopter, that means the lens is off by 30 degrees. That means residual correctable astigmatism divided by the total correction possible and multiplied by 30, because if we know that if the lens misaligns by 30 degrees, there is no correction of the astigmatism. So with that, if the patient had the one diopter of correctable astigmatism and total was supposed to be corrected by 1, that means there was no correction. 1 by 1 multiplied by 30, that means the misalignment is by 30 degree. But on the other hand, if there is a high power lens, total correctable was 6 diopter and the residual is only 1. So that means 1 by 6 multiplied by 30, that means misalignment, 5 diopter of correction has been already achieved. So misalignment is only 5 degree. So though the refractive error, the refractive surprise is the same. But in the second case, misalignment is only 5 degree. That means if we see into this chart, if there is a 1 diopter of residual correctable astigmatism, so IL power at a corneal plane, if it was 1, there is a 30 degree of misalignment. If it was 2, it is a 15 degree of misalignment. If it is 3, it is a 10 degree of misalignment. All these 3 patients can be taken up for the realignment because there is a significant misalignment. But if you see, if it was supposed to correct 4 and 6, then misalignment is only 7.5 and 5 degree, which will be very, very difficult to realign. That means if patient needed 6 diopter of correction, you got 5, 1 diopter is residual, you got to go with it. That is better than try to correct 5 diopter misalignment. So we need to, realignment is done when there is a significant misalignment and it can correct significant residual astigmatism. That means whenever you are using a lower power toric IOL, for the same amount of astigmatism, the misalignment much more and you can easily correct it. But whenever you are using a high power toric IOL, and even if there is a 1 diopter left, probably you cannot correct it by the realignment. So I'll just give you one example. This was a patient, 67 years male. Lens star reading was 1.39 at 92. Pentacam was 1.5 at 93. And we operated the multifocal toric IOL 16 1.5. And this is the picture. So uncorrected distance visual acuity was 618. Best corrected with the 1 diopter spherical, 1.5 diopter cylindrical at 30 degree was 6.6. So now we went back and did the lenses star reading, which was 1.56 at 94. Pentacam at 3 millimeter was 1.6 at 95. Patient was completely younger. And at 4 millimeter, normally I take between 2 and 3. 4 millimeter, it was 1.1 at 81.4. So we planned for, you can see the difference in the axis between at 3 millimeter and 4 millimeter. Here the lenses star helps you at 94. So we went and planned to put it at 90 degree. And correction achieved by this lens was more or less 0 because there was no correction. The lens was totally misaligned. So I don't have to take any photograph. I don't have to do anything. Just put the lens into shift axis because there is enough of misalignment which can be corrected. So there is no need to do anything. So the patient was taken into the operation theater and very simple. You open up the side port incision. You don't have to open the main port incision. We mark the 90 degree axis. And when I marked this, I realized that this, my mark was slightly on the temporal side. So I'm marking 90 degree slightly on the nasal side of this mark. You can see that. So this is what I call as a reference point. And I take a sharp chopper to make 3 indentations over there. This do I for the toric IOL. And then you can put on ink on top of that. And because the advantage of 3 points is that usually the peripheral most mark is more accurate because you are there's less parallax over there. And even when you are putting these marks, you can mentally analyze which of these marks are more at 90 degree. So this was the original side port incision. I usually make only one side port incision, but for repositioning, because I need an infusion from one side and repositioning from the other side. So I created another side port incision. And then this lens is very easy to rotate for sodium hyaluronate. And this is just 2-3 weeks old, so not very difficult. So just redial it, make sure it goes into the 90 degree. And again, before you withdraw your infusion, put an air bubble from top of it and press this lens back. So remove the viscoelastic from behind the lens, which is very, very essential. And this is where the sodium hyaluronate, Halon, Orogel, Gynate plus score over the methyl cellulose. So remove the complete viscoelastic and see the final position of the lens. Once the lens is finally positioned, put on an air before drying the infusion so that the lens is pressed back. And make sure that the incisions are well sealed before you leave the patient. So the post-realignment patient had plus 0.25 diopter spherical power 6.6, and even pre-operatively he had the spherical equivalent of plus 0.25. Thank you very much for giving me the opportunity and listening to it. Thank you very much.